Dear visitors of the European Heart Journal website, good afternoon. We are here live in Barcelona, directly from the world's leading congress in cardiovascular medicine, and I brought to you two celebrities in cardiology. I know they don't like it when I say that, but they are. The past president of the ESC, Professor Kim Fox and Martin Cowie. They don't need an introduction, and they left me today puzzled with presenting a trial with a great acronym, SIGNIFY.
Correct.
But what are we going to do with that? If you, Kim, who you presented that, give us a little intro and background. Some of our visitors of the website need a little bit of background on the drug. It's not available in all countries in the world, and we are a global journal. And then come to us, you left us with something really to chew on.
Yeah, and we're still chewing on it. The SIGNIFY trial is a trial testing Ivabradine. And before I go any further, Ivabradine is an IF current inhibitor. In brief, it's a drug that slows the sinus node. So it's a direct slower of the heart rate. It has no other cardiovascular effects. So it's a really good tool to test what happens when you slow the heart rate. So what we did was we looked at patients with Ivabradine in SIGNIFY, and we, based on work that we'd performed in 2008, we tested whether or not slowing the heart rate in patients with stable coronary disease and without heart failure is able to improve outcome in terms of cardiovascular death and non-fatal myocardial infarction. If I go backwards, in 2008 we did the beautiful study which tested Ivabradine in patients with coronary artery disease and left ventricular dysfunction. And although we did not find a positive primary outcome, we had a neutral primary outcome, a pre-specified subgroup in patients with heart rate greater than 70 showed that Ivabradine could improve outcome in terms of fatal and non-fatal myocardial infarction. So it seemed to us logical that we should test this in the group that are likely to get fatal and non-fatal myocardial infarction, that is people with angina, people with coronary artery disease, who also have preserved left ventricular function, because we're very well aware of the benefits of heart rate slowing in people with heart failure. Anyhow, we went on to perform the SIGNIFY study, 19,102 patients, so it's enormous, from 51 countries. So most countries of the world. 5,000 investigators. It was just an enormous project. And what we were looking at was people with coronary artery disease, increased risk factors, and who particularly we were wanting people with angina, and we were selectively trying to enroll people with angina and to test the effect of Ivabradine versus placebo on the primary composite output, that is cardiovascular death and non-fatal myocardial infarction. As a second pre-specified endpoint, which is the area that's caused much of the confusion, is that we had a good evidence from the beautiful study that the people who will do best are the people with limiting angina. So we selected a proportion of patients with limiting angina and to test the effects of lowering heart rate in these particular patients. It was not such a small subgroup. Of the 19,000 patients, 12,000 had limiting angina, that's class 2 and above, so it's really a big subgroup. And what we wanted to do is make sure that the patient had a really good heart rate reduction, so we really went for it. We started with a high dose of Ivabradine, higher than is usually used as a starting dose, 7.5 milligrams twice daily, and we up-titrated to a heart rate of 55 to 60 up to 10 milligrams twice daily, which is above the normal of 7.5 milligrams twice daily as the upper limit. So we really went for a good heart rate reduction, and we got that. Basically, the entry heart rate was about 77, 78 beats per minute. Usual regression to the mean over 3 months on placebo. The placebo came down to about 70. Ivabradine was 60. So there was a 10 beats per minute reduction in the heart rate. And these are people who were at high risk. 75% had a previous myocardial infarction, about 40% were diabetics, 20% had peripheral artery disease, 85% or so had hypertension, so they were really high risk. And one interesting thing that's come out of it, in spite of these people with angina, high risk, the actual event rate was only 2.8% per annum for cardiovascular death and non-fatal myocardial infarction. So maybe we're already there as the best we can do for angina.
So what did you find?
Right. What we found was that if you give Ivabradine over placebo, you have no improvement in terms of cardiovascular death and non-fatal myocardial infarction. No difference at all, no improvement. So
it was neutral on the primary.
It was neutral on the primary, so the conclusion that is absolutely clear-cut is that lowering heart rate with a pure heart rate reducing agent such as Ivabradine does not prevent the progression of coronary artery disease to myocardial infarction and death.
Before we come to the secondary, Martin, would you have predicted that?
Well, it's very interesting because the subgroup analysis suggested a strong benefit, and that's why he went on to do this specified prospective validation. It just shows you that you have to do those studies to confirm a subgroup from before, and it wasn't confirmed. There was no effect, neutral effect. It doesn't change the natural history of the coronary artery disease. 19,000 patients, big important study, no change in outcome. So for me, it was interesting to see that we always have to treat subgroup analysis with caution.
Once again, we've been a little bit misled by a subgroup analysis. Well, fair enough. I think it was a very strong rationale. It made a lot of sense pathophysiologically in stable coronary artery disease, and you achieved the heart rate reduction you wanted. It's a massive trial, and I think you found very exciting for us from a pathophysiological point of view, a very interesting finding that
it was a preconceived idea that
absolutely
that the heart rate was important in terms of stable coronary.
So let's digest that. The primary, that was neutral. So what happened with the secondary?
So now we've got a subgroup analysis again
of a trial that was okay.
Of a trial that did not meet its primary endpoint.
Yeah.
But the difference about this subgroup analysis rather than most, first of all, it was pre-specified, but it was a 12,000 patient subgroup. So there were 12,000 patients with class 2 angina or above. And what did we find? Remember, what we expected to find, that an even bigger benefit, although we got no benefit, but an even bigger benefit would be achieved. And what we found was the reverse. There was an 18% excess on the patients treated with Ivabradine in terms of cardiovascular death and non-fatal MI. And although the individual components didn't reach significance, they trended in exactly the same way.
So that was a hierarchical order of the secondary, and that was your first secondary? Is that
was our first secondary.
I'm still puzzled. Please explain that to me, Martin. Do you have an idea?
Well, I think even the investigators are still going through the data to get the message from it. I think, as Kim has mentioned, part of the fact is that maybe heart rate lowering doesn't change the outcome for these patients. The other thing was maybe it was excessive heart rate lowering, and I think, Kim, you can comment on this, that patients particularly on diltiazem or verapamil, which also have a heart rate lowering and a blood pressure lowering effect, did particularly badly when their heart rate was reduced even further with Ivabradine.
Because they also interact with Ivabradine as well, but through the CYP3A4.
In your intro, and that's how I always perceived it by using Ivra in my heart failure patients, but as well, we come to that in a second, I always found that a relatively well-tolerated drug with, I thought, a great, looked on paper, side effect profile.
But we used high doses.
Exactly.
And maybe that was our mistake.
And that's my question. Is that the case? Is that a dose? And is the heart rate reduction you achieved, was that too ambitious?
We can't actually very easily say it was the dose, because it was patients were dose titrated to a heart rate. It wasn't a parallel group study. But we certainly achieved a lot of bradycardia. 19% or so had either symptomatic or asymptomatic bradycardia as an adverse event. The vast majority of patients had a heart rate on Ivabradine had a heart rate less than 60. A very substantial proportion of patients had heart rates less than 50. I know it was down titrated if it was persistent. So we achieved a lot of bradycardia, and it may well be that we were over-ambitious. But whatever we say, and we'll actually have to understand what this means for the use of the drug in angina, but for whatever we say, I think we can firmly conclude that reducing heart rate does not prevent the progression of coronary artery disease. And that's maybe something we have to think about in the guidelines, where we really do think that heart rate down to 55 to 60 will improve outcome.
Let's hold that thought with the guidelines for a sec. I'll come to that to the end, and we want to give some guidance on this. But I would like to understand that. It's my curiosity behind that is, you lower heart rate in a stable angina population. Is it that you need to compensate for hypotensive effects with your heart rate increase, or something like that? Is that perceivable? But because we do know in stable angina, when we do harm, it's most often linked to hypotension and the way the body compensates for that. Is that a way?
I think that's where it's going to go. Okay. We're still looking at that. We're still trying to dissect that, but that certainly is the way I think it's going.
So now back to the guidelines, Martin. What should we do? We are heart failure guys. There, we love Ivabradine. Here in stable, is that now off the table in stable angina? Can we say that, or what's your guidance?
Well, moving to the heart failure arena, I mean, this is a totally different population from SHIFT. SHIFT had obvious systolic impairment, and the epidemiology supports heart rate lowering, and the randomized trial strongly supports it. And even if you look at the subgroup on SHIFT that had ischemic heart disease, so coronary artery disease, they had equal benefit with heart rate lowering with Ivabradine. So I think for heart failure patients, we can be very secure that the guideline doesn't need to change, to my mind at least. We want to get good heart rate control. Ivabradine often has to be used in sinus rhythm to get that heart rate control, and that improves the prognosis of heart failure in many different ways. I think for the angina guideline, I think I'd turn back to Kim, who's often more involved in those. I'm not sure what change, if any, is needed.
Well, at this moment in time, let's go with what the regulatory authorities are saying. That's probably the best way to move forward. At this moment in time, the regulatory authorities are emphasizing the current dosage of Ivabradine, not the dosage used in SIGNIFY. At this moment in time, they're also saying that you should not use verapamil, diazepam, and strong CYP3A4 inhibitors in combination with Ivabradine for the effect of bradycardia. But it's important to say also that they are evaluating the entire portfolio, and they will come out with some recommendations which we will have to heed when in a couple of months' time.
So what do you do with your patients who are on Ivabradine with stable angina?
I'm doing exactly what the regulatory authorities are saying to do. Don't do anything. Ensure that they are on the right dosage. In other words, ensure they're not on a high dosage. There's no reason to withdraw patients. There's no reason not to even continue to use Ivabradine in the way that it's registered with on the SPC. So at this moment in time, I'm doing nothing, because I don't use a dose of 10 milligrams, and I don't use it in combination with diltiazem and verapamil.
And in our heart failure patients, Martin?
I think it's no change. I mean, heart failure, as you know, it's 5 milligrams twice a day starting dose, unless they're very elderly, and it goes up to 7.5 BD, so it never goes near the 10 milligrams BD dose. For systolic heart failure, we've got great evidence of benefit. For diastolic heart failure, there's a trial ongoing, and it's continuing because there's no rationale to stop that. So I don't think there's any change for the heart failure patient. The change would be for somebody who didn't have any LV dysfunction but coronary artery disease. Don't use Ivabradine to change the prognosis of the condition. But Ivabradine, of course, is a good symptomatic agent for the control of angina, increase of exercise tolerance. So I think clinicians just need to think about what their therapeutic aim is for the individual, and what kind of heart problem does the individual in front of them have.
And the SIGNIFY trial actually confirmed the symptomatic benefit.
Wonderful. So once again, a drug that is totally safe in heart failure and it works. Not necessarily translate into those with preserved function or stable angina. And we learned a lot. I think we're going to learn a lot more from that. Sometimes paradoxical finding in trials are, from a scientific point of view, very important, because then we learn more about the pathophysiological backgrounds of that. And so I really learned a lot. I really enjoyed that. We are going to learn a lot more. And thank you for giving us guidance. Some just last final take home. Martin, you start, and Kim going to close.
Well, as a heart failure physician, this trial does not change my practice. Systolic heart failure, sinus rhythm, get good heart rate control. A lot of patients still use Ivabradine, but the top dose is 7.5 BD, and don't use it with diltiazem and verapamil, but I'm sure you weren't anyway.
Wonderful. Kim.
In angina, Ivabradine is an effective anti-anginal agent. Don't use it simply to improve outcome. That's not the reason in angina. Use it for angina, and let's hope we can use the paradoxical data to help our patients.
Well, what a wonderful final last word. Thank you both, and I really enjoyed that.